I'll introduce myself. My name is Octavia Wojcik, and I'm a program officer at the Robert Wood Johnson Foundation. My work there focuses on research evaluation and also building healthier, more equitable communities. And just to give everybody a little bit of background about the foundation, because I'm not sure that you're aware, we're the nation's largest foundation that is solely focused on improving the health of everybody in America. And to give you an idea of what that means, so about 3 years ago, we introduced the culture of health, the notion of a culture of health, our vision for what it means to be healthy in America. And it means much more than just not being sick. Being healthy means that you have the opportunity to be your best possible self. It really talks about different factors together, such as transportation, education, housing, community development, all of these different sectors working together to improve population health and well-being. And on the diagram, you'll see that there's these 4 diamonds, which represent the 4 areas that we believe we should focus on in order to improve population health, well-being, and also equity in the US. And it's really making health a shared value for everybody in the US, also fostering cross-sector collaboration between different sectors, and creating healthier, more equitable communities, also strengthening the integration of health systems and services. And I wish I had more time to talk about this. I don't. But if you're interested in learning more, please go to cultureofhealth.org to find out more information. So now to get a little bit closer to what we are talking about is really, again, this drilling down into data that is a very small geographic level. So that's something that we've heard at the foundation that there's a need for. Certainly health outcomes data are available at the national level, at the county level, to some extent at a city level, but then when you drill down a bit deeper, it gets a little bit harder. So along with the Centers for Disease Control and also the CDC Foundation, we partnered together on something called the 500 Cities Project, which you see a map of on the screen. Those are the 500 largest cities in the US. And the CDC was able to use a small area estimation in order to provide information on different health outcomes, prevention services, use of these services, and also risk factors in these 500 cities. And that data is available now, and anybody can use it. So if you're interested, please check that out. Another project that the foundation has been supporting, which will be releasing data in the coming months, so probably in April of next year, is the Life Expectancy at Birth project, which is going to also be using small area estimation to estimate life expectancy at birth for census tracts within the US, so basically neighborhood level. And that's going to be done for the entire nation, something that has never been done before. So that will be coming out shortly. So those are just some of the different projects that the foundation is supporting that are really innovative, I believe, and are cutting edge. And our 2 panelists are another example of such work. So joining me today, we have Jared Hawkins, who's a faculty member in the Boston Children's Hospital Computational Health Informatics program. Jared really works translationally, bringing digital health projects from research into implementation and enterprise. And his research focuses on digital phenotypes for population health surveillance, which I'm sure he will explain shortly. We also have Veronica Combs. She is the executive director of the Institute for Healthy Air, Water, and Soil. And the Institute develops new partnerships, supports citizen science projects, and builds support for health in all policy and decision making. So I guess to start off with, I've had the pleasure of working with both of you, so I know about your projects and the things that you do, but the audience does not. So I'd love for you to take a couple of minutes just to talk about your work and maybe also touch on the methodology that you use, because I think it's really innovative.
Great, thank you. So I just wanted to start, I guess, by describing my role, because I have kind of this joint role. So on the innovation side, I'm part of the Innovation Digital Health Accelerator at Boston Children's Hospital. And what we do is we support digital health initiatives at the hospital. We have a pretty diverse team ranging from clinicians to data scientists to engineers, researchers, business analysts. And we work to improve a few different things, but to improve clinical workflow at the hospital and also to create patient-facing apps, both educational and also really kind of improving patient care at the hospital. And so we work to support initiatives at the hospital that might be commercialized, and so that's part of the accelerator is to kind of build up kind of know-how and if possible commercialize it outside of the hospital. But we also work with external partners, which might be of interest to many of you, and ranging from kind of pure industry to other academia to government. And I think it's just really important that collaboration across all those different sectors to really facilitate innovation in healthcare. And my other side, on the faculty and research side,
The big green
yeah,
button.
thank you. Sorry. Let's see.
The one above it.
Oh, sorry, too many buttons. Okay, so I do work mainly focused around what we've termed the digital phenotype. And so the digital phenotype is really looking at all different types of digital data streams kind of in concert to better understand individual and population health. And so on this visualization, you're seeing kind of this individual that's generating a lot of real-time content, but of course is also this huge kind of retrospective corpus of data that can be used to really better understand, as I said, both individual as well as population health. And we've looked at a variety of different types of areas, from insomnia to mental health to autism to patient experience. But today I'm going to talk a little bit about the work we've done on patient experience with the Robert Wood Johnson Foundation. And so really quickly, I know it's hard to kind of go through a lot of data now. I'm showing, we've collected, so I mentioned we use a lot of different digital data streams. The focus of this project is using social media and specifically Twitter. And what we've done is we've collected tweets that are about patient experience, or really the access to care, so treating a patient as a consumer. Collected that data over about a 4-year period. And geocoded it down to the level of where the individual lives or is tweeting. And I'm showing you here on this really high-level picture just this notion of people are tweeting about patient experience all across the country. So on the top figure, you're seeing kind of tweet density per 100,000 residents. And so you're seeing there are varying levels of discussion, but this is still happening kind of across the country. And then on the bottom, you're looking at average sentiment. So this isn't a raw sentiment value. This is really just a ratio of negative to positive tweets. And so you can see that in general, sentiment, I know it's really difficult to read the scale, but in general, sentiment skews negative for patient experience. Obviously, this is different in different parts of the country, but this is an area we're really interested in diving deeper into. And so difficult to visualize this across this kind of large time frame, but what we're doing now is we're looking at specific patient populations. We're looking at rural versus urban. I know the last panel talked a bit about that. That's something we're diving into right now, and we should be submitting a paper for publication in the next few weeks. As well as we've looked into kind of at-risk or underserved populations. And so one of them has been kind of the LGBT community. And so what I'm showing you here is, again, using the same Twitter data, we are looking at kind of rankings of hospitals across the country based on their overall I guess, support or not, lack of support for the LGBT community. And this is based on the content of people who are tweeting about those hospitals in relation to specific LGBT issues. And so, again, at a high level, what you're seeing here is, as has been shown by other research, in the Northeast and the West, there tends to be a more supportive environment at these hospitals for LGBT communities. But even interesting within that, you see there are, within those regions, you do see there are some hospitals that are kind of less supportive. And so I guess I don't want to talk for too long, but the purpose of a lot of this is to kind of collect this data, do some analysis on it. I know you mentioned what we do. So we do a lot of machine learning, natural language processing, topic classifications, so try to automate this analysis of this large data sets. But to make it available to the public and make it available to stakeholders who could potentially, improve their own hospitals or, dictate policy both locally and regionally and nationally. I guess with that, I'll move on. I don't want to talk for too long.
So thank you for having me today. I'm from Louisville, Kentucky. We recently completed a project funded by the Robert Wood Johnson Foundation. It was a partnership between the Institute, a nonprofit organization, the City of Louisville, specifically the Department of Civic Innovation, and Propeller Health. Propeller Health made the technology platform that we used in this project. And I have to say that if you want to talk to me about Rick Pitino, I would rather have you talk to me about Google Fiber, because that news sort of landed on the same day, and those of us who are working on good things in Louisville were chagrined to hear basketball take the stage. So We live in a river valley. We have a ring of low hills around our city, and it tends to hold pollution in. Salt Lake City has the same problem. The mountains there are more dramatic, so it's a little easier to understand, but we tend to get inversions where polluted air is held close to the city on hot, still days. And so the American Lung Association does an annual report on air quality, and I think we've gotten an F for the last several years. Ozone and particulate matter are big problems. So the Department of Civic Innovation, they did not want us to be defined by our geography, so we wanted to look at outdoor air and quantify its impact on asthma and on healthcare costs for employers. So there's this little sensor that fits on top of a metered dose inhaler. Whenever a person took a dose of medicine, it recorded the time and the date. It sent that information to an app on a person's phone, which wrapped in location. So that gave us a snapshot in time of when a person was having trouble breathing. So we enrolled 1,100 people. We collected 250,000 data points about medication use, and because we had that timestamp, we could associate 5.4 million data points about environmental conditions. So pollen, pollution levels, humidity, and from all that data, we found that these are the most common triggers for asthma attacks in Louisville, Kentucky. The darker areas on the map are where a person with asthma is at most risk. Those dark areas down in the far part of the county are two big power plants. So sulfur dioxide and nitrogen dioxide come from burning fossil fuels, so that makes sense that those areas of the county would have more problems. And then the dark area in the middle is the University of Louisville, a historic district, the West End, which is typically a lower socioeconomic status, and also the downtown core. So lots of folks at risk for asthma. I think this is my second favorite map from the project. A couple years ago, the city counted all the trees in Jefferson County. Ideally, a city would have about 35 to 40% tree canopy coverage. Louisville's is at 31 and declining. If you've ever heard of the emerald ash borer, it's killing a lot of our ash trees, not just in Louisville, but across the East Coast. And a lot of our trees are just getting older and we're not replacing them. So if you look and see where there's lots of trees, there's fewer asthma attacks. In this last budget cycle, the City Council cut the tree planting budget in half. They made that decision right before our results came out, so I'm looking forward to meeting with them and saying, it's not really a nice to have kind of thing. Trees are central to our city's health. This is my favorite chart, which is a little hard to see, but it really illustrates a couple things. I met with about 10 different city departments. This was really a collaboration. We didn't want to work in a silo. We didn't want to do our own thing. We wanted to be out in the community talking to folks working on these issues. And we talked to the Air Pollution Control District, and one of the managers said, right in the middle of your project, one of our power plants switched from coal to natural gas. And she knew that that meant tons less pollution in the air, but it's hard to connect that to health. So if you look at the gray line with the blue bar in the middle of it, that's the level of sulfur dioxide in the environment in Louisville, Kentucky. And if you look at the red bars, those are rescue inhaler use. So as you can see, as pollution levels go up, so do asthma attacks. And then in that big May 2015 transition is when the power plant switched, because of the Clean Air Act, switched from coal to natural gas. So no one had ever really seen this direct correlation before. The other big blue bubble, another power plant switched, put better scrubbers on the stacks, basically. So it's really a direct connection between pollution levels and health. Some of these decisions to switch fuel are economic because right now natural gas is cheaper. But I met with the Chamber of Commerce last week, and I'm hoping to meet with our power utility generator next month to share this and talk about the impact of these decisions on health. So I think I've used up my time too, so I'll give that back.
Thanks very much. I think you started to touch upon this, Veronica. What are the policy implications for, I guess, the work that you have been doing on this project? And what are kind of your next steps?
So that was one of the Robert Wood Johnson Foundation's biggest goals for us. They didn't want us to just let this data sit in a spreadsheet, but to have it influence policy. The city is actually rewriting its comp plan right now, and so we focus on two areas. Right now, when a developer is building on a piece of land, they only have to replace 15% of the trees they chop down. So we've proposed a policy to increase that to 45%. Also, we found that living next to a roadway really increases your chance to have an asthma attack. So we've also proposed a policy to put a 500-foot buffer between busy roadways and sensitive populations. It's still all going through the process, but those are two specific things we've done.
Thanks for that. I wonder if you can both talk a little bit about the different challenges that you encounter with your work, both in relation to the data, talking about your work, really sharing your findings. I'd love to hear a little bit more. Jared, maybe you can start.
Sure. I mean, I guess there's lots of challenges, but a few challenges would be, one is just access to data. It's finding really just finding the data and being able to generate it. Social media is less of an issue. Some networks are more open than others. We've focused on Twitter just because it's been generally a pretty good partner and the data is somewhat freely available. But so first would just be access to data. Second would be kind of developing the tools to make sense of it. It's not just automating the analysis, it's also kind of sifting through it and trying to find a story out of just this massive amount of data and these different analyses you could run. And then I guess the final piece is really just doing something with it. And so what we try to do is make data available back to people, back to government, back to any kind of interested stakeholders. But it's really finding how to put that data in the hands of somebody who can do something with it. And so I'd say those are the three big challenges.
What about you, Veronica?
The last analysis that we wanted to do was to work with employers around claims data. We've worked with 7 employers in Louisville, including Papa John's and Brown-Forman, to enroll their employees in the program, and we wanted the employers to look at claims data before this intervention and after. I think, as I mentioned, asthma is the #1 reason that little kids go to the ER in Louisville, and so we were hoping that we could see a change in healthcare utilization. That's pretty sensitive data. You get sued for mishandling that data, so that's been a difficult conversation. But it certainly got people thinking about it in a different way. It's not just, well, we have to live with asthma. It's missed school days, missed work days, higher healthcare costs for employers.
I wonder if you can talk a little bit about what you hope the impact of these projects and your work overall, what you hope it can be, and specifically in trying to move the needle on the different disparities that we see both within cities and nationally.
Well, to go back to the framework that you started with, we hope to make clean air a shared value for everyone. We take in about 24,000 breaths a day, but we don't necessarily think about what's in that air. And in Louisville, you can't look outside and see a bad air day. It takes about a year off everybody's life if you're healthy, and if for sensitive populations with asthma, it's worse. So we're really hoping to build awareness. The Robert Wood Johnson Foundation also funded an art installation that visualized this data. And so it was a huge touchscreen. It's in a school right now. And the particles of pollution were illustrated by these dots that floated across the screen. So the more polluted the day was, the more dots covered the screen. So we're really hoping to get people to see that population health includes clean air and working to make infrastructure changes and personal decisions that really support that.
And I'd say, for us, again, it's kind of going back to what I said before, it's really kind of shining a light on what people are saying, right? Mm-hmm. So if, back to the LGBT work, some hospitals might not understand or know or maybe not care of what's being said, at least on social media, about kind of the perception specifically for LGBT communities. And so I think it's, both making that available to the public to kind of, not really to shame a hospital or an organization, but really just to make it, transparent that this is what the community is feeling, and then back from a hospital perspective, really just making them aware so they can improve engagement with that community. And then back to the larger level of just looking at kind of access to healthcare. Again, I think it's there are lots of different data streams that try to address this issue, and we're just trying to introduce another one that tends to be a bit more real time and also tends to pull opinions from people who might not be contributing to other data streams. And so really just trying to provide a voice to people who might not have one when it comes to amassing some data that will influence policy.
So saying that we're running out of time, my final question to you is going to be, what can the audience here do? So thinking about what can you challenge them to do? What are the needs and the gaps, either in terms of data, funding, or other aspects that you would like the audience here to help with?
Sure. I mean, quickly, because we are running out of time, I think the big two issues are data. So, collaborating with groups like ours that are really just interesting in using this data for public health, population health research. Being willing to collaborate and share. And then the second piece is, collaborating in terms of resources as well. As I mentioned from the Innovation Accelerator, we're really interested in collaborating with others that, are best in breed, along with, computational techniques and different approaches. And so I think that collaboration of data and resources is key.
The Institute is a really small organization. We're 3 years old and there's 2 of us, and partners are how we get everything done. As part of the asthma work, we identified a hot spot that was out near the malls, and there was also a school right across the street, and they had this beautiful open front yard, and we said, we'd like to test the air quality and plant a bunch of trees and test the air quality again. And they said yes. And so if someone comes to you with a strange request, I would just ask you to say, yes, we will be your partner to get this work done. I really think that's a solution to these big problems like diabetes or poverty or air quality, that it really takes a unique set of voices in the same room talking about it to find innovative solutions and to find partners that can fill the gaps of funding or just ideas or data.
Great. Well, we don't have time for questions, but if anybody is interested in speaking with any of us, there's going to be tables, and we are going to be at the one that is focused specifically on city data and frameworks, new frameworks. So thank you, everybody, for listening, and please join me in thanking the panelists for the discussion.